It gives me great pleasure in introducing the first speaker, so Dr. Parijat who is presenting the, must get the pronunciation right, no, apologies if I don't, Smethwick Community Pathfinder Diabetes Project, Right Care, Right Here. Dr. Day, over to you.
Good morning, thank you for inviting and setting up a program, QiC Diabetes first of all. And I'd like to present this Pathfinder project. It's Smethwick Pathfinder project, and I'll tell you where it is. I'm presenting this on behalf of my colleagues, and I can see some of them in the audience. For people who don't know a lot about Birmingham, Smethwick is the west of Birmingham. Diabetes is pretty rife. It's a pretty deprived area and a big challenge for us to work there. And no surprise, therefore, that the prevalence of diabetes is almost double the national average there. And as has been the case in many a place in the country, there were lots of threats from CCGs, erstwhile PCTs, to take out diabetes services into the community. And that sort of formed the basis for initiating something different and seeing whether that worked or not. And the challenges, particularly in our patch of the world, was integrated diabetes care was pretty much non-existent. And these are the 5 pillars, if you like, of integrated diabetes care that was lacking. The first one was lack of clinical engagement and partnership between primary and secondary care, and nobody knew which patients to follow up where and how to follow these patients up. The second was lack of joined up care and engaged patients, partly because of lack of clarity on part of patients to learn, engage and self-manage, but partly because of the problems of delivering structured education programs like Expert and Daphne. Poorly integrated IT systems, and I think that is still a big problem in many a part, and it was the similar case in our area. And as a result of this, what we found was referrals weren't coming in as expected. There were delays in communication and, of course, a lot of duplication of services. Poorly demarcated financial boundaries, and that still is a big problem. A lot of patients in primary care with poor, languishing HbA1cs were still in the community for financial reasons, and there was a tendency in the hospitals, as we've seen a number of times, to hold on to simple patients just to follow them up once every 6 or 12 months. And as a result of all this, there was clearly a lack of robust clinical governance system and a structure in place, leading to problems in management of diabetes patients. So this project was set up some 15 years ago, called the Pathfinder project, or the Right Care, Right Here approach. And it started off with 2 practices initially, and later on expanded to about 7, 8 and 9 practices in 2010 and 2012 to address some of these unmet needs. And what happened in these clinics was very, very simple, really. The GPs and practice nurses would identify difficult cohort of uncontrolled diabetic patients, for example, HbA1c above 69, for a one-off management and advice plan by the consultant and a DSN pair that would go in and offer help once every 2 or 3 months, depending on the capacity. And the primary care team would then take this forward and put it into action. There were criteria for referral set in within these clinics, mutually agreed, of course, with our GP colleagues. And various forms of consultations evolved from joint consultations, advice and guidance, case notes review, education. And an ongoing audit of the whole process was set up, not only depending on the frequency of clinics, what parameters to measure, and of course there was a financial model worked out. The rationale for this whole model was to ensure that there was seamless working rather than the us and them divide that we often see. Also, it was very important to try and devolve care out into the community, to try and reduce the DNA rates, because a lot of times patients weren't coming into the hospital as expected. The essential reason was to build up capacity and capability within primary care so that only appropriate referrals would be made into secondary care. And in doing that, in empowering GPs and practice nurses, we thought it would probably help build up the self-management plans, and structured education would be much better embedded. Of course, along with this, the evidence-based pathways and protocols were set in, and we hoped that formulary compliance and value for money prescribing on the whole would also improve as we went along. I think diabetes management skills in primary care improved significantly. We did patient and user satisfaction surveys, and there were some excellent results there. And this is just a quote from one of the GP practices: excellent service, innovative, wish such clinics were more often. HbA1cs also improved, and I've just given a snapshot from 7 practices. Between 57 to 62% of these practices improved their HbA1c over a 2-year period. There was increased uptake of expert education program. From January 12 to December 13, 300 patients attended expert program, and for the first time we also started the Asian version of the expert, slightly abbreviated program. There were cost savings in this Right Care Right Here model of care. I won't be able to go into details. For example, in 2012, 50% of the patients seen in one of these, in a few of these community clinics were all patients discharged from the hospital. I don't have time to show you the QoF figures, but there were consistent improvement in QoF figures from all the practices that we audited. And reduction in complication and hospitalizations from ketoacidosis improved, amputations improved, and hopefully the whole health economy as such would have benefited. And this model was something that we've been going on in discussions with our CCG partners, and I'm delighted to say that it is coming up to a year. The CCG has recognized this model, and we have this model now called DICE, Diabetes and Community Extension, embedded into majority of the practices within Sandwell and West Birmingham. And hopefully I'll be able to present a little bit more in a year's time. Thank you.